And now welcome our last but not least speaker, a personal colleague and friend, Professor Ahmed Shawky, Professor of Cardiology in Ain Shams University, who will tell us heart failure is not as easy as it seems. I think none of us thinks it's easy, but it's still a very attractive title. Professor Ahmed Shawky is Salafi.
Professor Hani, everybody, it's been a lovely meeting. I've enjoyed everything so far. It's excellent. Dr. Said, as usual, very nice. Thank you, Dr. Said. Actually, it's a good thing that I chose this title because I really changed the case very late because I had another case coming up for follow-up, which was really interesting. And this case is a 56-year-old gentleman. He's an ex-smoker with recurrent history of asthmatic attacks and sinusitis. He's been hypertensive for the past 8 years. He's taking many different medications, but beta blockers usually had an aggravation of his asthma attacks. And of course, he was a smoker, but he stopped. So he presented to a hospital with an acute shortness of breath, and his troponin was positive in this hospital. There was ST segment depression in the lateral leads with an impaired ejection fraction, as you can see, and segmental wall motion abnormality. Okay, so it seems like an acute coronary syndrome. What to do? Rush to the cath lab. And he was, an angiogram was done. And as you can see, nothing of significance. I'm not going to go into details of the angiogram, mild atherosclerosis. So diagnosed as a case of myocardial infarction with non-obstructive coronary artery disease. So he was given dual antiplatelets, high-dose statins, small dose of valsartan, post-myocardial infarction, and ivabradine because of the beta blocker intolerance that he has because of his asthma attacks. So, okay, seems like a case that we see every single day, and we're just going to follow up. But this is the presentation that I saw, which was 4 months after the first presentation. He came with chest pain, acute chest pain. He went to the ER. There was some shortness of breath, and with that, on examination, he was orthopnic. There was bilateral lower edema. There was a little bit of basal rales. Actually, the blood pressure was 140/90, heart rate was 90. There was a little bit of rash on his arms, and he had an apical third heart sound. Chest pain, shortness of breath, but mainly chest pain, actually. His ECG, again, you don't see something of major significance. There was no ST segment changes that signify a big insult. But we went into the labs. His creatinine was okay. His ESR was elevated. CRP was also elevated. His CBC showed lymphopenia and eosinophilia. So we're talking, is this positively a COVID myocarditis or something like that? But actually the PCR for the COVID-19 was repeated twice, was negative. His troponin was markedly elevated. You can see the numbers, maybe 30 times the normal. His end-terminal proBNP was also increased, and his chest X-ray and followed up by a CT showed bilateral pulmonary infiltrates, and the report said not typical of COVID-19 actually this pulmonary infiltrates. So what are we doing here? Is this another acute coronary syndrome? So he was admitted to the CCU, simple as to go. He has chest pain, he has shortness of breath, he's a little bit congested, IV diuretics, IV nitrates, simple as that. But what about antiplatelets? Do we do it? He's already on aspirin, clopidogrel, because again, ticagrelor really aggravated his asthma attacks. Do we do another coronary angiography? Is this a repeated case of Minoka? So actually, when I passed upon this patient and looked up and asked for the further investigations, I said, no, we're just going to control the symptoms. This might be some sort of inflammation. This might be some sort of COVID-19. But actually, later on, I said, this is not a COVID-19 myocarditis. He's been negative. So the echo this time, instead of 42, it showed a drop in the ejection fraction to 30 with increase in dimensions, mainly the end systolic. And non-diastolic, the diastolic function was actually grade 2 diastolic dysfunction with global hypokinesia. So what's the next step? Actually, I wasn't rushing into an angiogram. I said we will stabilize the patient, and then we're going to send him for an MR. And we did the cardiac MR. And what did it show? It showed mild myocardial patchy scars, basically, mostly involving the interventricular septum, And these are cuts. I just want to cut it short. But what's important, it's suggestive of chronic inactive myocarditis. So this is myocarditis. And this is MR done maybe 2 to 3 weeks after discharge, because the patient, had a little bit of problem getting to do the cardiac MR. We stabilized them, and this shows that this is a myocarditis. This is not an infarction. The patient has myocarditis. But what to treat, what to give? He has pulmonary infiltrates, what to do? What's the diagnosis? And this is the important thing, because if you don't know what the patient has, you don't know what the treatment plan will be. Okay, we're giving supportive therapy for his heart failure. We're giving supportive therapy for his congestion, but this is not the final. So what's the cause of all death? So we asked an immunologist, and they helped us, and we follow them up, myself and the immunologist, quite frequently. They asked for a wide array of investigations. Anti-nuclear antibodies negative, ANCA was negative, the C-reactive protein was elevated just on admission. There was an increase in LDH, no anti-streptolysin OTH, infectious screen for any type of myocarditis was not significant. There was an increase in IgE. Of course, don't ask me what does this mean, because I'm a cardiologist. I don't know what this means. But after that, they put him on a score chart done by the American College of Rheumatology after they evaluated the patient, and they looked at the history of asthma, the eosinophilia, which was an important marker for diagnosis, the pulmonary infiltrates, which is not uncommon in these diseases, and the paranasal sinus abnormalities, which was seen on many CTs. And this actually goes up to a high predictive value for diagnosis of what we used to call the Churg-Strauss syndrome, or the eosinophilic granulomatosis with polyangiitis, which is the new name of Churg-Strauss. So a little bit of history. This was seen in the early 50s, and it was characterized by asthma, eosinophilia, and granuloma formation, and some vasculitis. This has many differential diagnoses. It has a prodroma phase when there is asthma, allergic rhinitis, and eosinophilic phase when there is eosinophilic infiltration and increasing the eosinophilic count, and there is a vasculitic phase. But our patient had myocarditis. There was nothing in the vascular tree. The pathogenesis actually affects mainly the medium-sized muscular arteries, but there are data that it can infiltrate the tissues with eosinophilia, and this can happen. Its manifestations are multiple. There are systemic manifestations of fever, weight loss, maybe joint pains. It can cause pulmonary involvement with patches as seen in our patient. We can see nervous system involvement in some cases, like neuropathy, which is very common in certain patients. A rash, which the patient did come with, and they told us retrogradely it could be the rash of Churg-Strauss. This is not the picture of our patient. Gastrointestinal involvement, including eosinophilic gastroenteritis, pancreatitis, or even cholecystitis and peritonitis. It can cause renal involvement, which usually has a focal segmental glomerulonephritis. But the leading cause of death, and this is something I did not know, is cardiomyopathy and myocarditis, especially eosinophilic myocarditis. So this patient had this. And actually myocarditis, which is the most common eosinophilic myocarditis we know is the Loeffler syndrome, which mainly is restrictive cardiomyopathy. But no, in Churg-Strauss or EGPA, it does occur. There are 3 stages. The first stage is in which there is infiltration of the eosinophils into the myocardium. Then there is hypercoagulability and formation of thrombi. But here, could this thrombi have induced the acute coronary syndrome that was seen in the first presentation? And then there is fibrosis, and then there is permanent cardiac dysfunction. And actually, if you do a cardiac biopsy, you will find this eosinophilic infiltration. We sent the patient, and we told the patient for a myocardial biopsy we was going to do it at Magdi Yaoub's center in Aswan, but the patient refused multiple times, actually. But the rheumatologist and the immunologist said this is probably a case of that and that. So how do we diagnose this disease? There are 4 out of 6 criteria, the criteria that we use to diagnose our patient. This is the American College of Rheumatology classification, but there are 2 other ones, the Lanham's criteria, in which it has to include asthma, eosinophilia, and systemic vasculitis in 2 or more extrapulmonary sites. the Chapel Hill consensus, which is asthma, eosinophilia, and inflammation informing the respiratory tract or vasculitis in the small to medium vessels. And we should take into consideration there are so many different laboratory investigations that we might not find. And actually, an ANCA-negative Churg-Strauss syndrome has a very high predictive value that it can cause myocarditis. Actually, most cases of myocarditis occur in the ANCA-negative, not the ANCA-positive Churg-Strauss syndrome. And I know you're thinking this could be another disease. Yes, in the allergic phase, it mimics sarcoidosis. In the eosinophilic phase, it can mimic rheumatoid arthritis or hypersensitivity pneumonitis. And in the vasculitic phase, of course, the biggest differential diagnosis is polyarthritis nodosa and Wegener's granulomatosis, but the myocarditis in these two diseases is quite rare than the Churg-Strauss syndrome. How do we treat? And this is why we're trying to find a diagnosis. The patient was put on medications, but this is just a review on what treatments can be given. Glucocorticoids, there can be cyclophosphamide, intravenous steroids in certain cases, even up to intravenous immunoglobulins and our monoclonal antibodies. Our patients are also having a good or poor prognosis. This is according to the French Vasculitis Study Group scoring system. If we have a one factor of the 5 above, which is elevation of the serum creatinine, proteinuria, GIT involvement, cardiomyopathy, or CNS involvement, then you have a 5-year mortality. Look at the number, 25. It's not something to be taken very lightly. If you have more than 2 factors, it can go up to 46 or even higher. So our patient who started on corticosteroids and cyclophosphamide, of course, the doses definitely were not according to my recommendation. It was according to the rheumatologist. And actually, this is why I tried to change the case, because he just came last week to me. After 5 months, he's ambulant, his ejection fraction is improved. He's still on sacubitril valsartan, ivabradine to control the heart rate because beta blockers really aggravate the asthma, eplerenol. And this is a really lovely case to see why the change in the definition of heart failure, that this patient, you might think myocarditis will resolve in nearly all patients. This patient has an impaired ejection fraction. This patient has not a recovered ejection fraction, has an improved ejection fraction, and this is the new definition as published just a month ago. So hope I didn't take a long time. I know it's late at night, but heart failure is a common complication from different entities. And this eosinophilic granulomatosis, the Churg-Strauss, that's the older name, is a very rare condition. I haven't seen it maybe twice. This is the second time I've seen it. And it can cause multiple system affections. The cardiac involvement, which is quite rare, is the #1 cause of death in these patients, actually. And the correct diagnosis, you might think, okay, so what? If it's Wegener's granulomatosis, we'll give steroids. No. Actually, the management might differ from different diseases and the doses might differ from different diseases. But actually, we were able to reach the diagnosis, and this patient may be doing well because we are treating him correctly. And thank you.
Thank you very much, Professor Ahmed. Like the 2 previous presentations, this is a very special presentation because it shows that medicine is not mass production. Patients are human beings, and for the patient with a rare condition, like this case you just showed us, or the amyloidosis case we saw a little bit earlier, it's so important that somebody remains on the hunt, remains vigilant, and diagnose their case. Even if, as you said now, you will see in your entire professional career only a few of such cases, but it is extremely important to keep on going after the diagnosis, despite the frustrations, despite the fact of whether even a condition has a treatment or does not. And this is very important. I just want to ask you one question. In Egypt, we don't have a lot of myocardial biopsy. Do you think this is something that we should do something about? I mean, instead of like having to send them to Aswan. I mean, I see no reason. I see no reason why a place like Ain Shams University or the Heart Institute or Cairo University would not have a myocardial biopsy. It's actually not a very technically challenging procedure.
Actually, we did have it, and and also I think in the National Heart Institute you had it, but again,
Yes.
there was a lot of demands. There was a lot of changes in the guidelines, and actually there's not a really big interest. But I think when you have something, actually it's very simple. I've seen maybe 5 or 10 cases, but it's not done a lot right now, which is a bad thing. Sometimes they help. It's not very commonly used, and there are guidelines when to use them and when not to. But yeah, it's not a demanding or a technically problematic thing. But actually, our patient did not require the myocardial biopsy to be 100% diagnosed. Yeah. But I agree, it would have finished the whole diagnosis and made it clear as water.
Yeah, I just find it very strange that Egypt, with a 100 million population and maybe 10 or 15 cardiology departments in universities and big government hospitals, does not have even one center where we can all refer our cases. So maybe we can take an advantage of this small meeting to focus on this point. Maybe we can do something about it. Thank you very much.
Thank you.
Is there any questions from the audience?
Yes, please. Professor Haney?
Hi,
Professor.
You're looking wonderful.
Thank you, dear. Professor Ahmed, it's amazing. I really enjoyed, it's quite a rare case, and I would like to ask you, what grabbed your attention primarily that this could be the diagnosis of that case?
First of all, I just hate everybody with chest pain and a little bit of troponin to just go to the angiogram repeatedly. And he just had an angiogram 4 months ago, which was actually nothing of significance. We're in the era of COVID, and in COVID, actually, we see a lot of myocarditis. And this was my first diagnosis. This is myocarditis due to COVID. This patient might need, antiviral and corticosteroids and stuff like that. And we work as a unit, actually, with the pulmonologist, with the immunologist, with the nephrologist. I'm not going to talk about the doses of the things I don't know. We get whoever can be there. PCR was negative. Okay, so there's something else. We repeated the PCR again, negative. So we were looking at other things, and actually the person who really put this into consideration, I'll tell you, the MRI does not diagnose Church-Strauss or eosinophilia, but it was the rheumatologist, and just following up our patient between me and the immunologist really helped us go there. But I did not have, I said the myocarditis, and what it is, I don't know, to be honest.
Yeah, thank you very much. Just one quick question, quick comment. Professor El-Sayed, I'm so thankful for this wonderful meeting, and I just want to say that, do we need, as cardiologists, to implement the SGLT2 inhibitors as part of our armamentarium in the treatment? I've seen a lot of cases tonight, and all of them are wonderful cases. And I think that I have not seen in either of them the SGLT2 inhibitor as one of the cornerstone medications that we should implement in our treatment. Should we revise our strategies and thinking, even in non-diabetics, etc., etc.?
Dr. Khalid, I'd like to answer this question, because as you see from those fantastic case tonight, the turning point here was a procedure which changed the management, changed the heart failure status, changed the aggressiveness of the heart failure progressiveness. So that's why tonight the procedure done in a lot of cases turned out the management phase of the management of the case. So that's why it might be, yes, I totally agree with you that it might be one of the medication options, but here we give the message that you have to think sometimes that the procedure may change the phase of the management of the case. According to the case of Professor Shawky, I think that the story is totally different here, because the steroids, which is contraindicated in the treatment of the heart failure, here is the treatment of this case. So I think those are the messages came up from the cases, which was really, I totally agree with you. Despite we are in the case box, but all the cases are out of the box, actually. All of the cases are out of the box. Thank you all. Professor Hani, if you allow me, if there is no any further questions, and as you said, yes, Professor Tariq, please.
I would like to thank Professor Ahmed Shawky for this excellent case presentation. I think that the feedback from this case, we have to search for the diagnosis of heart failure. And the key points in such a patient, the presence of eosinophilia, and the white cell count was high. The leukocytic count was 14,000. This is not in favor of viral infection. The leukocytic count was high due to the presence of eosinophilia, and the patient has skin rash together with lung infiltrates and the history of asthma and normal coronaries. We have to search for another cause for this is a learning feedback from this case. We have to search for, and the cardiac MRI in such situations is very helpful for diagnosis, whether the amyloid cardiomyopathy or the eosinophilic cardiomyopathy. Very important. We have to search or to use the cardiac MRI for such diagnostic purposes. I thank you for such.
I see here, Dr. Tariq, as you said, a comment from Dr. Karim that it is important always to lock a simple measure as a differential CBC. Differential CBC may be a clue for diagnosing the Professor Shawky case. Professor Hani, if you allow me, please, to conclude this fantastic night with wonderful out-of-a-box cases in the case box fifth wave. I'd like to thank you all, Professor Ashraf Reda, Professor Atif Al-Bahari, Professor Ayman Abu Al-Majd, Professor Hani Raghi for their wonderful moderation of the cases, and also the case presenters, Professor Karim, Professor Heba, Professor Shawky, Professor Kispo, Professor Rafael, and Professor Stefania Oliveros, Professor Raghda Sheikh, Professor Tariq Al-Zawawi. I'd like to thank you all for your wonderful presence tonight, and I promise that we will keep going the case box waves with Jack case reports with another wonderful cases. Thank you all and have a wonderful night. Bye-bye.
Bye. Bye.
Bye.
Bye.
You.
Bye-bye.